just from the outpatient services when this building was still under construction. And very quickly, within few months, in 2017, nephrology services were started, and then later on, renal transplant was initiated. And it's a matter of pride that now over 600 renal transplantation procedures have been done, and more than 200 in the last 1 year. The quality of these services is enormous and very impressive in terms of the quality of preoperative, peroperative, and postoperative care of all those patients. And the other services, including immunology, pathology, critical care, infectious disease management, this has all been developing throughout along this journey. And some other important landmark achievements have been done. One of them is pair kidney donations. I think it's quite to 24 of these patients in the last 2 years which have been benefited from this program. Then renal transplant in the last year has been done in patients with compensated cirrhosis. And the steps are also being taken, and few procedures with ABO incompatible. And I think 3 procedures have been done where simultaneous liver kidney transplantation has also been achieved during the last year. And all these achievements have been accomplished despite the fact that in COVID year, almost 1.5 years, this institution was totally closed for routine work, and we managed only COVID patients, and all our ICU beds and all other rooms were specified for the COVID patients of only, where this institution served almost whole of the country, where people used to feel secure even coming from Lahore, from Peshawar, from Karachi, to get themselves treated for COVID complications. So I think this institution, with its enormous strengths, its qualified staff, enthusiastic doctors and paramedical workers in all fields, are here to grow this service of renal transplantation. I am very much grateful to experts who have come from across the Atlantic as well as from here, and they will enrich in today's symposium our knowledge, our skill and expertise. With this, I announce this symposium open. Thanks very much.
Our first speaker, Dr. Mahjabeen Imam, is a proficient consultant immunologist in Pakistan Kidney and Liver Institute. I am delighted to invite her to share some tricky scenarios in immunology.
Assalamu alaikum. I am Dr. Mahjabeen Imam, working as consultant immunologist here at PKLI, and today I am going to share some real-time experiences regarding renal transplant immunology. So first of all, A'udhu billahi minash shaitanir rajim, Bismillahir Rahmanir Rahim. So exalt the name of your Lord, the Most Great. Then I swear by the setting of the stars, and indeed it's an oath, if you could know, Most Great. So we will start off with pretty basic knowledge, just for the sake of revision. Baseline immunological investigations include HLA typing of both donor and the recipient, lymphocyte physical cross-match, and anti-HLA antibody screening. And on the basis of the results of these, we will select the best course of treatment. So, first of all, we will start off with pretty basic knowledge, just for the sake of revision. Baseline immunological investigations include HLA typing of both donor and the recipient, lymphocyte physical cross-match, and anti-HLA antibody screening. And on the basis of the results of these, and on the basis of the results of these investigations, we will decide what to do next. Next, please. So the first case is of a 51-year-old female, mother of 3 children with ESRD due to unknown cause, came for the initial pre-transplant immunological workup with her son, who is 30 years old, as the potential donor. So the results of the HLA typing and the rest of the investigations in our this pair was 1 haplotype match with 3 antigen mismatch out of 6 loci, and lymphocyte cross match was negative, and anti-HLA antibody screen was also negative on the initial presentation. Everything was fine up till now. Then after 3 months, this lady again came for a repeat cross match, and when this cross match was repeated, it came out to be positive for against both T and B cells. So what had happened between these 3 months? We took so the sample for DSA estimation was taken, and it showed that DSA against 2 HLA alleles, 1A and 1B, was found to be positive with MFIs of 7500 and 2500 respectively. So how did this happen? On detailed history taking, it was found that patient was transfused 3 pints of blood 8 weeks back, and this blood transfusion has led to the formation of this allo-sensitized antibodies. So final diagnosis was made of pre-transplant allo-sensitization due to RBC transfusion. As we all know, the events that cause allo-sensitization include blood transfusion, pregnancy, and previous transplant history. So there are some data that I want to share. The impact of pre-transplant transfusion on allo-sensitization. The rate of allo-sensitization is higher in patients who have received pre-transplant transfusions as compared to those who have not received any transfusion. Also, the number of transfusions that the patient had received is directly proportional to the amount of allo-sensitization. And Paris females receiving pre-transplant transfusions are at increased risk of developing allo-sensitization when compared to their non-Paris female counterparts. And males have also an increased risk of sensitization after pre-transplant transfusion compared with non-Paris females. And this sensitization occurs due to the phenomena of allo recognition, which takes place by 2 phenomena, direct and indirect. So this basically is the graphical representation of what I just said, that the number of transfusions, just like for the patients who have received more than 5 transfusions are more prone to develop allo-sensitization as compared to the patients who have received less than 5. Now, to discuss the impact of allo-sensitization of on allograft outcomes, allo-sensitization is basically linked with higher rates of graft rejection and lower rates of graft survival as compared with their non-sensitized counterparts. It is reported that when compared with non-sensitized recipients, sensitized individuals have lower graft survival when checked at 1 year, 2 years, and 5 years post-transplant period. Now, considering the impact of donor-specific antibodies, several studies reported that the presence of donor-specific antibodies was associated with more acute graft rejection episodes as compared to the non-sensitized one. And also, the US RDS 2010 annual report, the risk of graft failure was higher in allo-sensitized versus non-allo-sensitized patients. So this graph here, again, it is showing a meta-analysis of different studies in which 2 types of patients were catered. Sensitized one with black bars and the non-sensitized one with the white bars, and the prevalence of antibody-mediated rejection was found to be statistically significant in patients who were sensitized as compared to the non-sensitized one. So for this case, further plan of action is now we are searching for a more suitable match for this patient with lesser number of mismatches. Also, if this has not happened, then we will move towards desensitization protocol for this patient. So we move to our second case, which is a 43 years old female a mother of 4 who were delivered by cesarean section, came to with ASRD to the OPD, and her potential donor was her husband. On initial immunological workup, she was found to have 6 out of 6 antigen mismatches on all A, B, and DR loci, and negative flow cross-match. However, anti-HLA antibody screening was strongly positive against both class 1 and class 2 alleles. When a single antigen bead assay was done, it was found that there was no donor-specific antibodies. However, plenty of third-party antibodies were there. Then she was proceeded with the transplant, and after a few days of transplant, her serum creatinine shot up and DSA was sent. Extremely high IgG was detected against every single mismatched HLA allele, and the combined MFI was around 30,000. And on renal biopsy, it was diagnosed as antibody-mediated rejection. So this is a learning point for all of us, because in this case, there are 2 risk factors involved. Number 1, choice of donor, which is husband, as she is a multiparous woman. So we will discuss in the light of some studies, like what is happening in husband-to-wife transplantation. Despite very improved immunosuppression techniques that we are using right now, there is still higher risk of death-censored graft loss, possibly mediated by a higher frequency of antibody-mediated rejection as compared to other HLA mismatched transplants, either living or dead, in patients with multiparous women. Previous cohort studies published between 1995 and 2008 reported 1-year graft survival rates between 78 to 90% in husband-to-wife transplantations, which is much lower than the other comparison groups. And a lower frequency of prior pregnancy will reduce the overall risk of husband-specific sensitization, which can critically influence the outcome. So this graph is basically showing the red line is the group of husband-to-wife transplant, the green one is the deceased donor, and the blue one is the living donor. So death-censored allograft survival is much less in the group of husband-to-wife transplants as compared to the disease and living donor transplants. And patient survival is surprisingly 100% in the husband-to-wife group, although it's much lesser for disease donor transplant. So there are plenty of publications which highlight that husband-to-wife transplantations are associated with wide range of outcomes, ranging from uneventful courses to subclinical or severe rejection. Unfortunately, currently available parameters like HLA typing and DSAs and the number of pregnancies are not capable to accurately predict the outcome, but if we manage to analyze the molecular level of HLA disparity, for example, applet load and applet immunogenicity, it will provide much better prediction. Another interesting approach will be to look for memory B cells. So this graph again is showing different types of rejections in all these 3 groups. Clinical rejection, subclinical rejection, and T-cell mediated rejection is showing similar results in all the 3 groups. However, subclinical antibody-mediated rejection is much higher in husband-to-wife transplant group. So in this case, what should we be doing? We should be counseling the pair in evaluation for husband-to-wife transplantation. It is recommended to use optimum immunosuppression, including ATT induction, and it is extremely important to discuss the higher risk of rejection as well as failure. Alternative living donors should be sought in this case, and if not available, then this case should be enrolled in a disease donor program, or it should be included in paired kidney donation. From a statistical point of view, a woman with 2 full-term pregnancies has a 40% risk to be sensitized against any one mismatched HLA allele of the father. Now, we will talk about some biological impact of pregnancies. This impact was first identified in 1950s, and there were J.J. Von Rode and colleagues who were studying transfusion reactions in peripartum women. These studies were first to reveal the presence of a factor later to be known as antibody in the serum of Paris women that could mediate agglutination. The cytotoxic capacity of this antibody was later used in vitro to determine the prevalence of alloimmunization in pregnant women. When checked on cytotoxic dependent CDC, it was estimated that around 30% of women developed anti-HLA antibodies during pregnancy. When more sophisticated techniques are used, like single antigen bead assay, this figure moves to 50 to 75%. And population-based studies of both transplant candidates and blood donors suggest that 24 to 49% of women with a history of pregnancy have detectable allo antibodies. So why does this happen? Pregnancy basically primes maternal T cells and other immune subsets. So this figure on the left side shows the maternal blood when it is contaminated with the fetal antigens. Fetal antigens pass through the placenta and goes into the maternal lymph nodes, where they are presented by antigen-presenting cells to the naive T cells. Could be CD4 or CD8. So all kinds of immune responses are generated. Usually they are effective. Usually they are anergic. They tend to produce T regulatory cells. And the most important one are the ones which activate follicular T helper cells. And these follicular T helper cells then activate the B cells and form antibodies against the fetal antigens, which are going to cause the problem. Although most women with a history of pregnancy or transfusion do not develop antibody in sufficient quantity, pregnancy alloimmunization appears to result in a broader sensitization than transfusion, maybe due to two of these reasons. Number one is higher antibody burden to a limited number of HLA specificities, or true broadening of antibody burden beyond paternal HLA specificity. Like these antibodies are against public epitopes of HLA alleles. Pregnancy alloimmunization increase rejection rates and reduce post-transplant graft survival. This potentially occurs because of memory T cell responses or enhanced production of anti-HLA antibody from pre-existing maternal plasma cells. Now we come to a third case, which is a case of 36-year-old male with ESRD due to unknown cause, who came for the initial pre-transplant workup with his 37-year-old brother as a potential donor. He was also 6x6 mismatch at ABDR locus. Flow cytometric and CDC cross-match was negative against T cells, but it was found to be positive against B cells. And anti-HLA antibody screening was also negative for class 1 and class 2 alleles. What to do now? So this is a not very uncommon scenario. Every now and then we find this kind of finding, where antibody screening is negative and cross-match is coming positive or borderline is there. There are certain points that we need to consider in such cases. Detailed history of blood transfusion or any surgical procedure should be taken, which we did, and it came out to be negative. We check for infectious marker screening, and then we check for autoimmune markers. We ask for the administration of drugs such as rituximab, ATG, or IVIG. And then we also check for prozone phenomena when higher titers of antibodies interfere with the estimation of true results. And we do some interventions like heat inactivation or serum dilution, or using EDTA or DDT to overcome this prozone phenomena. Then we also consider the role of non-HLA antibodies like MICA and red cell antibody screening to rule out Lewis antigen. How we have proceeded, we did the autoimmune profile of this patient, and he was found to be positive, strongly positive for anti-nuclear antibodies in very high titers. So the final impression was IgG autoantibodies, which are lymphotoxic and complement binding in nature. As per the guidelines of British Transplant Society, the presence of autoantibodies of IgG nature with positive CDC or flow crossmatch in the absence of HLA or LO antibodies do not confer any additional risk to renal transplant. Now I come to the last case, which is a 28-year-old female, mother of two, who came for pre-transplant immunological workup with her 37 years old sister. Her lymphocyte cross-match came out to be negative. However, on HLA antibody screening, high levels of IgG were detected against class 1 and class 2. Is there anything which is missing here? So they are basically identical matched on HLA typing. So we proceeded with the transplant and no further investigations were done. So this graph here is showing graft survival versus the number of mismatches. The less the number of mismatches, 0 to 3 mismatches are associated with better graft survival as compared to the large number of mismatches that we have. Thank you. Any questions, please? Ji. So the first question, the DSA flow hota hai, that is the quite different. It is commercially available kit-based method, or it is not very much studied now. उसके साथ उसके commercial negative or positive controls आते हैं, और usually centers they are not using it because it's not optimized. Major difference उसका यही है कि वो बहुत commercial उसके use के लिए होता है. दूसरी चीज़ जो आपने कही कि if screen is negative, then usually there is no need to do single antigen bead assay because it's expensive and it is causing a lot of burden for the patient. But yes, if the physician wants it, we can do it.
So congratulations on this very nice presentation. So what about DQ timing, at least for sensitized patients? I mean, patients who have been transfused, patients who are women who have had pregnancies. I think they might be sensitized against DQ antigen, DQ alpha or DQ beta. And how do you work out with DQ testing?
So the DQ typing is not for screening purposes. We use for second step when, as you already mentioned, that when sensitization is there, we go for DQ typing and then we check for the DSAs against DQ as well. But in all the cases that I have discussed, it was already established by other entities as well.
With regards to your very interesting second case, husband to wife donation,
Yeah.
which is very demonstrative as what we should avoid as a result, I mean ABMR. And for the screening of that potential of the recipient, did you screen for SAB straight away? Because, I mean, I would advise when the husband is donating to the wife, we should straight away test for SAB because by definition, she is sensitized against her husband.
We did check for SAB before transplant, but at that time there were no DSS. Only third-party antibodies were there.
But Dr. Rostang, we are doing DQ typing. We are doing DP, we are doing C and DQ. And even we are doing for DQ alpha also. We have the facilities.
ठीक.
Is there any safe period between the pregnancy and expected allosensitization being there, or it's a lifelong, like memory plasma cells are going to be there?
Memory cells will be there.
Would be there ever,
Yeah.
and there is no safe limit for that.
No. At least not to my knowledge.
So the last question regarding DSA flow cross match, I want to make a comment too. Regarding the latest patient I did, DSA flow cross match was completely negative. I still went for SAB, and it turned out to be an MFI of 6,000 plus.
Exactly. This is what I'm talking about. DSA flows are not optimized, and
But Aurangzeb, one point to your answer question also that the screen is total. The phenotypic beads are all negative, class 1 and class 2. You will still go for a DSA. You will still go for DSA if your B cell flow cross match is positive. because the sensitivity of the phenotype beads is not so much as compared to the donor,
Exactly.
single antigen bead. Many times I've done with the flow cross match is coming T and B cell positive, and the screen is completely negative. And then we are going for the single antigen bead, and we're coming with the class 1 antibodies like 7,000, 8,000 MFI. The sensitivity of the bead on single antigen bead is much higher than our phenotypic bead, which we do for the class 1 or class 2.
Thank you.
Dr.
Thank
Howard, you want to add?
Sorry, Dr. Rosting, I have a question for you, please, as well. Dr. Rosting, are you doing SAB in all your cases? Or first you are going for screening and then you are going for SAB? Or you are doing for all the cases?
So, costly wise, if it's a male patient, never transfused, never transplanted, we do not need any immunological workup. I mean, just HLA typing, and that's it. Because the likelihood of finding DSA is nil. Conversely, for patients who have been already transfused, transplanted, or women who have had miscarriages or pregnancies, we always straight away perform SAB. So, yeah. But we can afford that. So.
Thank you.
And regarding the flow cross match, as you pointed out, indeed, if your flow cross match is optimized, you may pick up every single low-level DSA that which result in positive flow cross match. Conversely, if your flow cross match is not sensitive enough for various reasons, various issues, well, it's not reliable, and so therefore, as you said, well, you have to be very cautious in the way you will accept or deny a potential donor. But if you work very nicely in an immunology lab, you can rely on your flow cross match.
Now we are honored to welcome Professor Dr. Lionel Rostang, Head of Department of Nephrology, Grenoble, Alpes, France. He is renowned expert in field of kidney transplant. Dr. Lionel will discuss T-cell mediated rejection in kidney transplantation and role of surveillance biopsies. He'll also discuss treatment of TCMR and share his enriching experience.
Assalamu alaikum, dear colleagues, friends. Thank you so much for the invitation, Dr. Adil and all the PKLI group. It's my real pleasure to be here again. The first conference you were having was last year in October, so I'm very glad to be here. So, can I have the first slide, please? Okay, so the title is the gathering of three different subjects. Is T-cell mediated still a threat in kidney transplantation? The role of surveillance biopsies, and is there effective treatment for chronic TCMR? So I tried to do my best to cover these areas with the evidence-based medicine. So the first question is rejection still a problem in kidney transplantation? It's a bit provocative, but it's important to address as such. So with regards to acute rejection, you have T-cell mediated and antibody mediated rejections. So as you know, T-cell mediated rejection is quite rare, provided the immunosuppressive regime implemented post-transplant is strong enough. So it's less than 10% of patients. In my center, we perform mostly deceased donor transplants, 75%, and the rest is living donors. We have around 7% of acute rejections, of acute T-cell mediated rejection. So it's a very rare process. And it mostly occurs when we wean off steroids, because all the patients are wean off steroids either at day 5 or at day 90, according to the protocol biopsy they have. And so we may face with acute TCMR after steroid withdrawal. But also we may face with acute TCMR in the setting where the patient is non-compliant, non-adherent to his medication, or when the immunosuppression is minimized for various reasons. And it's easily reversible thanks to methylprednisolone pulses or ATG if needed. Conversely, antibody-mediated rejection are still an issue. Regarding acute ABMR, it's quite reversible, provided you come along with steroid pulses, plasmapheresis, rituximab, and so forth. Oh. Next slide, please. I'm sorry. Okay. Okay, so as it was said, antibody-mediated rejections are mostly DSA driven, okay? Okay, so this will be addressed later on in the pathology session, but as you know, wherever possible, when you suspect acute or chronic rejection, you have to perform a kidney biopsy, and the renal pathologist will, grade the kidney biopsy according to the Banff classification. The last classification was published in 2019 according to active and chronic lesions. Okay, so I will not spend too much time on the Banff classification for cellular rejection, but just to remind you that cellular rejection belongs to the category 4, and it's graded either acute TCMR or chronic TCMR. And with regards to acute TCMR, it's graded A1, 1A, 1B, 2A, 2Bs, 3, according to the severity of the lesions and according to having or not having moderate antimal arteritis lesions. But this will be addressed later on in the pathology session. And so indeed, it's very important to have a quantitative scoring of the inflammation as well as the tubulitis. And regarding tubulitis, for the definition of T1, the presence of a single inflammatory cell within one tubule is sufficient to classify as T1. So this was a picture of of acute T-cell mediated rejection. As you can see, there were a lot of inflammatory cells in the interstitium, as well as pointer is not working, and a lot of tubulitis. Here you can see the tubulitis foci, as well the dilation of the capillary. Thank you. Okay. And this is an antimol arteritis which depicts the V lesions, and this is important to see these lesions and to be recognized because the treatment will be different. It will rely on ATG therapy if you've got these V lesions. So we have to also address the impact of the presence of inflammation in areas of tubular atrophy, IATR. And in that study performed some time ago at the Alabama University by Rosie Mannen team, it was shown that those patients having inflammation in areas of tubular atrophy areas had a significantly worse prognosis as compared to those in whom there was no such lesions. And as you can see, 3 years post-transplant, those in whom there were some inflammation in areas of tubular atrophy had a very poor outcome. 50% of grafts were lost. So it's very important to identify such patients and to optimize immunosuppression accordingly. What about borderline changes? So borderline changes are very upsetting because the question arises still now is to know whether they have to be treated or not. So borderline changes means that it's a category 3. It means that there are foci of tubulitis, T1, T2, or T3 with minor, in that setting, with minor interstitial inflammation, so no inflammation or only I1, or interstitial inflammation I2 or I3 with very mild tubulitis, okay? And this defines the borderline changes. And indeed, by definition, there is no intimal arteritis. And so for those lesions classified as borderline changes, we have to take into account the setting in which the biopsy was done. Was it a routine biopsy, that is to say a surveillance biopsy, or was it a for-cause biopsy? Indeed, if it was a for-cause biopsy, creeping serum creatinine, for example, I would treat the patient as such, like an acute rejection. Conversely, if it's only surveillance biopsy, I'm not sure it's worth to treat it. Okay, so this is a study from Korea. I'm sorry for the colors, but these are patients who had a chronic aerograph injury by subclinical borderline changes. Those patients who were desensitized pre-transplant, or those in whom there were episodes of T-cell mediated or antibody-mediated rejection were excluded. So these are the patients who never had rejection, who were not desensitized, and who presented with borderline changes. And so the patients were divided in 3 groups. Those patients in whom there were normal biopsies with a control group, and those patients having borderline changes, the group who was treated and the group who was not treated. And the question, it was a retrospective study, but the question was, is the treatment would benefit for those having borderline changes as compared to those having not been treated? So first of all, when they compare at 1 year down the road, the eGFR for those who had normal biopsies as compared to those who have had borderline changes, you see the eGFR is similar. Borderline changes were either treated or not treated, okay? And the patients were submitted to follow-up kidney biopsies, okay? And this is the index biopsy, and this is the 1 year biopsy. And they look at for changes regarding chronic changes, okay? And so what they found was that those in whom there were changes, there was an increased score, then there was an increase in the chronic score. And when they split it out, those patients who were treated with methylprednisolone pulses, the increase at 1 year in the chronic changes was significantly lower as compared to those that were not treated. So from that study, it appeared that if you have borderline changes and if you treat them with methylprednisolone pulses, if you reperform a kidney biopsy 1 year later, you would have a significant decrease in the chronic changes as compared to those who were not treated having borderline changes 1 year before. But it's a retrospective study. Okay, so what about chronic TCMR? So chronic TCMR was defined in the BANT 2019 classification of BANT. So grade 1A, it's interstitial inflammation involving at least 25% of sclerotic cortical parenchyma and at least 25 of total cortical parenchyma with moderate tubulitis involving 1 or more tubules. And this not including severely atrophic tubules, okay? And indeed, you have to rule out other causes of IFTA. Grade 1B, it's almost the same criteria, but the total cortical parenchyma is T2 or TI2 or TI3 with severe tubulitis. And finally, grade 2, it's chronic aerograph arteriopathy with arterial intimal fibrosis with mononuclear cell inflammation in fibrosis and formation of neointima. So these are vascular lesions associated to this T-cell mediated rejection. However, this may also be a manifestation of chronic active or chronic ABMR or mixed ABMR TCMR. And so at the end of the day, it's very difficult to classify this grade 2 as pure chronic TCMR. There might be ABMR associated, and therefore this might be associated with de novo DSA. Okay, so these were for the definitions. So now we're going to move to HLA sensitization and rejection, and thereafter to protocol biopsies. So this is a very nice study from Switzerland that included almost more than 500 patients. And the patients were classified according to CPRA pre-transplant, 0, 1 to 50, above 50, and having or not having DSAs. And so there were 4 groups of patients accordingly. And if the patients were to have pre-transplant DSA, induction therapy was based on ATG and not on basiliximab. And also if there was a DSA pre-transplant, because most of them were deceased donor kidney transplants, they were given IVIG in addition to that. And all the patients have had protocol biopsies, and this is very important, month 3 and month 6. And the mean follow-up was greater than 5 years. So first of all, if you focus on the incidence of TCMR, according to the CPRA traits, you see that CPRA has no impact upon the rate of TCMR, okay? It's the same rate. Conversely, if you focus on the incidence of ABMR, you see ABMR is almost only present in those patients having pre-transplant DSAs. Conversely, whatever the rate of CPRA, the incidence of ABMR is actually the same, provided there is no DSA pre-transplant. And so the key point is, if you want to address ABMR issues, you have to have a very good workup pre-transplant in order to determine whether you have or not DSAs. And with regards to patient survival, to graft survival and death-censored graft survival, there was no impact of the CPRA levels pre-transplant. Conversely, there was a huge impact of having DSA pre-transplant. So at the end of the day, the main message I want to convey is that the level of CPRA pre-transplant is not an indicator of TCMR rate or graft survival, provided you have no DSA on board. Okay, so from the protocol biopsies, and this is a series of Edmonton group in Canada, whereby they, according to protocol biopsies, they were able to figure out the scope of the lesions that we were able to encounter. So T-cell rejection is a very early event. As you can see, it's only early post-transplant, before day 90 roughly. TCMR, it's a process. This is, it's not working. TCMR, it's a process that you can encounter all along the transplant journey. Conversely, transplant glomerulopathy, that is to say it's a surrogate for chronic ABMR, is increasing over time, and IFTA lesions are also increasing over time, as you can see in green. But T-cell mediated processes are either acute very early on or chronic, and it can occur all along the transplant journey. Okay, so now we move to the different types of acute rejection and their outcomes. So this is a study from the Paris transplant group. So they used to perform protocol biopsies 1 month, 3 months, and 1 year post-transplant, as well as at the same time they monitor for the presence or absence of DSA, de novo DSAs. And with that in hands, they were able to address the subclinical acute rejections. This will be in the next slides, and to grade the different types of rejections. So this is their work. So in that series of patients, there were more than 2,000 de novo kidney transplant patients, and of these, more than 300 have had biopsy-proven acute rejection. Okay, and according to this to the biopsy findings, they classified the patients according to having or not having arteritis, okay, V lesions, okay, into TCMRs with vasculitis or arteritis. This is the green circle, or TCMRs having no arteritis. This is the red circle, and on the right-hand side, you've got the ABMRs with vasculitis or arteritis in blue, or without in purple. And as you can see in the middle, you've got overlappings. And indeed, at the same time, you may have TCMR and ABMR lesions with having arteritis. But it's very rare to have at the same time T-cell mediated rejection and ABMR without vasculitis. And so when you compare the some lesions, that is to say microvascular inflammation, you see microvascular inflammation is almost found in the patients who have ABMR. Those are the columns in purple and in blue. So purple it's with vasculitis and blue it's without. Transplant glomerulopathy, it's only observed in the setting of ABMR. Interstitial inflammation, it's mostly observed in TCMR settings, but also in ABMR without vasculitis. C4D deposits are mostly observed in patients having ABMRs. Don't forget it's biopsies at the time of acute rejection. Anti-HLA antibodies, that is DSAs, are by definition only observed in the setting of ABMRs. And finally, tubulitis is by definition present in the setting of TCMRs. But also, you see, you may have tubulitis in the settings of ABMRs, particularly in those who have no vasculitis. So just to summarize, you see 2/3 of the patients with ABMR and V lesions also showed interstitial inflammation and tubulitis. So you may have at the same time the occurrence of the two processes. And this suggests that having a mixed ABMR and TCMR lesions at the same time. And so how does it translate in terms of outcomes? So this is this is the graft survival according to 2,000 patients protocol biopsies. Okay, so if you have no rejections in your transplant journey, the outcome is perfect at 72 months. If you have had a T-cell mediated rejection, the outcome is quite good. I'm sorry, it's not working. It's a blue curve. And if you have had ABMR, indeed, at the end of the day, the graft survival is worse. And when they split it out, those patients according to having TCMR with or without vasculitis and having ABMR with or without vasculitis, you see the worst outcome is for those patients having ABMR with V lesions, okay? And finally, they looked after the risk factors for graft loss. And they found that if you have interstitial inflammation with tubulitis score greater than 3, it's a risk factor for graft loss, as well as having an inarteritis score greater than 3, having a DSA, and if you were to be treated with steroid pulses, plasmapheresis, IVIG, and rituximab for those who have had ABMR, the outcome was better. So to summarize, if you've got endarteritis, high endarteritis score, and DSA, the outcome is very poor. This is another study, quite a long time study performed in UCLA, whereby the patients were, this is the graft survival according to the type of acute rejection. So if you got only cellular rejection, the outcome is perfect. If you've got ABMR, the outcome is very poor. Conversely, if you've got mixed rejection, the outcome is in between. Okay, so now we move to protocol biopsies at 1 year post-transplant for patients who have no features of acute rejection. So it's a protocol biopsy. And so the question is to know whether it helps for predicting the subsequent outcome, okay? And so this was a prospective cohort of patients, 1,300 patients who were consecutively transplanted and all had a CDC negative cross-match at transplant. And so the protocol biopsies at 1 year were stained look after for C4D deposits, and the DSA monitoring was done at at transplant, month 3, month 6, and 1 year. And the patients were stratified into 3 groups. The group of patients, the majority, who has had in the past and at the time of biopsy no rejection, and 2 groups of patients who at the time of a 1-year biopsy had either subclinical T-cell mediated rejection, it was 13% of patients, and 14 had at the time of a protocol biopsy subclinical antibody mediated rejection. So their serum creatinine was stable, everything was stable, but the findings found subclinical TCMR or subclinical ABMR. So these are the protocol biopsies at 1 year, and so regarding the microcirculation inflammation, by definition, when you have no rejection or subclinical TCMR at 1 year, you don't have MVI lesions. Conversely, if you were they were present in the cases of subclinical ABMR. With regards to C4D deposit, it was almost exclusively present in the setting of subclinical ABMR. With regards to transplant glomerulopathy, by definition, it was only present in those patients having subclinical ABMR. Conversely, interstitial inflammation was mostly present in patients having subclinical TCMR, but also in some patients having subclinical ABMR. With regards to IFTA lesions, they were present all across the 3 groups. But bear in mind, it was mostly deceased donor kidney transplant with a lot of ECD donors. So this might explain why, when you have no rejection at 1 year post-transplant, you have some IFTA lesions. And these IFTA lesions were significantly increased in those having subclinical TCMR, but also in those having subclinical ABMR. With regards to arteriosclerosis lesions, it was present in the biopsy without rejection. Bear in mind, the patients were recipients of deceased donors, and most of them were ECD donors. If this explains this finding, subclinical TCMR arteriosclerosis lesions were similar to those without rejection. And conversely, those having subclinical ABMR had a significant increase in arteriosclerosis lesion. It means that they've got endothelial injuries. And when it comes to the outcome of this graph, because this is a prospective study, so the patients have had a protocol biopsy 1 year post-transplant, and it was either normal, in black, or subclinical TCMR. And in the case of subclinical TCMR, the immunosuppression was accordingly modified with steroid pulses in most of the cases. And you can see, if you've got subclinical TCMR, the outcome is very good, provided you treat the patient, you treat the event at that point. And with patients having subclinical ABMR, even though subclinical ABMR was handled as such at the time of biopsy, you see the outcome is poorer. And the outcome is particular. So this in the y-axis, this is the incidence of graft loss. Okay. In the x-axis is the eGFR. So to the right, it's greater than 60. In the middle, it's 30 to 60, and to the left, so it's the converse. So it's greater than 60, 30 to 60, and lower than 30 to the right. Okay. And so as you can see, the allograft loss, particularly those who have ABMR, is the maximum when the eGFR at 1 year is lower than 30. And it's far much less if the eGFR is 30 to 60. So it means that if you've got at 1 year post-transplant subclinical ABMR and you treat the patient as such, if your eGFR is good or well, in between, the outcome is not that bad. Conversely, if you've got at 1 year subclinical ABMR plus a poor allograft function, even though you treat the subclinical ABMR, the outcome is very poor. So it might help to decide how to treat the patients, or how to handle the patients at the time of biopsy. So a few words of T-cell mediated rejection and the outcome according to the type of immunosuppression. So this is the benefit studies. The benefit studies are phase 3 studies, 2, one addressing the standard criteria donor and one addressing the extended criteria donors, in which The control arm was cyclosporine A-based therapy, and where the two arms on the study were based on belatacept therapy, either more intensive MI or less intensive. And all the patients have had basiliximab induction, were having MMF, and were having steroid therapy. And this was a 7-year study. And so I show that study because it's quite interesting. Next slide, please. I'm stuck. Next slide, please. Okay, previous. Okay. So as you can see, this is the acute rejection rate over 7 years. For the cyclosporine A-treated patient, this is the bottom line, so the rate of rejection was very low, around 10%. The patients were not HLA sensitized, so it was a standard patient. Conversely, in those who were treated with belatacept from the time of transplant, you see there were about more than 20% of acute rejections. This was mostly cellular rejections, and they occurred within the first weeks or months post-transplant. And in spite of having had a high rate of acute rejections, the outcomes were very good because the best outcomes were observed with patients treated with belatacept as compared to cyclosporine A. This is patient and graft survival at 7 years. You see up to 4 years, there is no difference at all across the three groups. Conversely, the difference is appearing later on. And in spite of having had higher rejections, so T-cell mediated rejections, you see that the EGFR for those who were treated with belatacept is far much higher as in those treated with cyclosporine A. It means that acute T-cell mediated rejection in the setting of this therapy, belatacept, has no impact upon graft survival, upon EGFR. And finally, even though they have had more TCMRs, this has had no impact upon de novo DSA, because you see on belatacept, almost no patients have had de novo DSAs as compared to those who were receiving cyclosporine A. Okay, so don't forget that one of the risk factors for developing de novo DSA resides in subclinical T-cell mediated rejection. This is a meta-analysis that was performed some time ago. Okay, so now in the best world, we may rely on molecular microscope diagnostic system, which is the MMDX. Why is that? Because as clinicians, sometimes we have there are some discrepancies between the clinical symptoms, the creatinine level, and the histopathological data. And so therefore, it's difficult in some cases to reconcile the histopathological findings and the clinical data. And so the MMDX system was set up by the group of Philippe Adoran in Edmonton. And so how does it work? So this is the transcriptomic profiling of kidney graft biopsies, and this provides some information in clinical, as I said, unclear cases. And this revealed transcripts who are associated with disease progression. I will show you some data. And if we compare the MMDX data to semi-quantitative histology assessment, transcriptomic results are not only quantitative, but also are more specific. And finally, the other advantage of molecular assessment is the ability to adequately assess small tissue samples, 3 millimeter in length, independently of the proportion of cortex and medulla. As you know, for the histopathology analysis of kidney biopsy, we need to have cortex tissue, otherwise we cannot interpret. For the MMDX approach, it's not mandatory to have cortex. It's better for sure, but it's not mandatory. And so in the MMDX, or with the MMDX platform, there are ensembles of algorithms that will provide probabilistic estimates of rejection and injury based on exclusively molecular findings. So there is an automated report combining many rejection-related scores. We're going to see the graphics and the position of a biopsy relative to the reference sets of biopsies. And so this shows like that. So you've got the cohort 1 and cohort 2 were two cohorts of kidney biopsies that define, based on molecular findings, the groups of patients. And so you have the normal biopsies, the T-cell rejection, the ABMRs, and in between you have the overlap patients. And also, you can classify your biopsies according to BK virus nephropathy. And so this is the set of data that establish the MMDX tool. And then when you come with your biopsy, your index biopsy, the biopsy will be classified according to these different classifiers: normal, T-cell mediated, ABMRs, or mixed. So it's very helpful, but it's very costly. And in Europe, there is a single center in Prague that is able to use this methodology. So practically wise, we are not using it. But the concept is fascinating, and this might help reclassify some biopsies. And there was a study that they performed, and they compared MMDX results as to histological results. Okay? And they look at the discrepancies. And so maybe you might not be able to see from the back, but at the end of the day, there were some discrepancies, and it helps in some settings to reclassify the biopsies. Believe me, you cannot see from the back, but you've got normal biopsies, you've got T-cell mediated, ABMRs, mixed rejection, and so forth, and you have the outcomes. Okay, and a few words, because we are clinicians, regarding chronic active TCMR treatment. And so I Googled, and I just found two recent papers addressing chronic active TCMR treatment. So one paper is from UCLA. So it's a retrospective single center study reviewing 48 cases, not that many, of isolated chronic active TCMR, okay, of which only 44 were treated with pulse steroids or ATG or both, okay? And they found that according to a treatment response with regards to eGFR rate recovery, this was found in 20% of cases. Only 20% of patients were able to improve their eGFR following the treatment of chronic active TCMR, and it was diagnosed on a for-cause biopsy, okay? And the treatment responsiveness was not significantly different between cases with mild, moderate, and severe parenchyma scarring, okay? There was a trend towards greater treatment responsiveness in cases with moderate as opposed to severe tubulitis. So the less tubulitis you have on your chronic active TCMR, the best response to therapy. And in addition to that, they made a transcriptional profiling of the kidney biopsies, and they found that those patients who had allograft, who have increased allograft mast cells, and those who have alteration in lipid metabolism were identified as possible features of treatment-resistant chronic active TCMR. But the number of patients is very limited to draw any conclusion from that. And although the prognosis is generally poor, chronic active TCMR is not homogeneous, as demonstrated by this study, and the improvement of kidney function might be achieved in some patients with immunosuppressive therapy. So it means that it's worth taking the risk or the chance to give a dedicated therapy for chronic active TCMR should it be found on the for-cause biopsy. And the second study was published last year. It's a retrospective study from Japan, single center study, 37 cases were diagnosed with chronic active TCMR, and of these, 32 were treated. They were treated either by methylprednisolone pulses or ATG. And the patients were subsequently observed So 2 patients died, and 5 patients, this is 13%, developed end-stage renal disease. And in a univariate analysis, they found that if a patient has to have higher urine protein to creatinine ratio and Banff CICD score high, were risk factors for allograft loss. And of the treated patients, 23 out of 32 underwent subsequent biopsies, and they found that there was a significant improvement in Banff scores TI and T-IFTA after treatment. And based on pathology findings, more than half of the patients who underwent follow-up biopsy improved to no evidence of rejection or borderline changes. So it means that in that series of patients, small series, if you were to treat chronic active TCMR, half of the patients will have a clearance of their chronic active TCMR on the follow-up biopsy. And in multivariate analysis, it was shown that the lower UPCR was a predictive factor for response to treatment. So this might be helpful. That is to say, if UPCR is very high, maybe it's pointless to attempt to treat the patient. These were the single 2 studies I found in PubMed addressing the treatment of chronic active TCMR. I'm sorry. So to finish with, so handling borderline changes on kidney allograft biopsies is not yet well defined. So when your pathologist tells you, okay, there are borderline changes on a 4-course biopsy, you have to treat the patient according to your serum creatinine, according to clinical features, and so forth. Chronic active T-cell-mediated rejection is quite rare. And in that setting, methylprednisolone pulses with or without ATG might be helpful, as we've seen in the 2 studies so far. MMDX platform might be very useful to refine diagnosis in cases where the histopathology findings are inconclusive, but as I said, I've never been able to use it because we have to ship the biopsies to Edmonton, Canada, or to Prague in Czech Republic, and it's very costly. It's about 2,000 euros. And protocol biopsies are very useful, particularly at 1 year post-transplant, in order to detect subclinical rejection. And should you implement a protocol biopsy in your program, this should be 1 year post-transplant in order to detect subclinical rejections. With that, I thank you for your attention.
So thank you so much. Such a wonderful talk. Regarding the 27% rejection rate, what disease donor transplant program, or was there any live-related renal transplants too?
Oh, yeah. So in my center, yeah. So we have a living donor kidney transplant program. It's roughly 1/4 of the kidney transplants yearly done. And for living donors, we have less than 5% of TCMRs.
So was there any subgroup analysis? Because we mostly, am I audible? So we're mostly interested in the living donor.
Yeah.
So we are doing, sometime when we are doing disease donor, extended criteria donation, the things are less than perfect. So the expectations are a little different in terms of the live donor. So I was just interested, is there a subgroup analysis which will tell us what is the rejection?
Yeah. So there was a registry study from the US and one from Australia and New Zealand addressing rejection rates in living donor setting, which is your question. And the rates were very similar to those observed in deceased donors for TCMRs, okay? For ABMRs, it depends on the risk, risk of the recipient, and so the answer might be different.
And if I may, is there any role of donor-derived cell-free DNA, fractionated versus unfractionated, in the diagnosis of this one?
You mean cell-free DNA?
Yes, cell-free DNA.
I never I never use cell-free DNA assay because, first of all, because it's expensive, and I think it's pointless. The only setting in which this might be useful in the setting of ABMR. Okay, when you're setting of ABMR, I think it's better to use DSA assessment, SAB test instead of cell-free DNA. Cell-free DNA is just a marker of endothelium injury. That's it. Okay, it's not the point. The point is to know whether the patient has de novo DSAs, or he may have no de novo DSAs because he has non-anti-HLA antibodies. Okay, and at the end of the day, at that point, you will treat the patient accordingly. And so, if you add SAB plus cell-free DNA, so the cost is very high and it's pointless. So I refuse to use cell-free DNA assay in my center. And in France, no center are using cell-free DNA assay.
And in cell-free DNA, it has been more validated in acute antibody-mediated rejection rather than TCML.
Yeah,
but it has got
you're
a
right,
very good
you're right.
negative predictive value.
Yeah.
If it is negative, then you're
Yeah.
sure there is no immunological phenomena going on.
Yeah, yes, for sure. But you can use SAB test, and so, okay.
Dr. Rosteng, there's just one practice point in Pakistan, and my SAUT colleagues are also have. After the treatment of early TCMR, we are just relying on the resolution of the creatinine for the
Yeah.
that we have done an adequate treatment, whether we are giving ATG or pulse methylprednisolone. Follow-up biopsies are not being done too much. We have started now in PKLI, and we have decided a time to do a follow-up biopsy at 3 months. What is your suggestion?
So in my center we have protocol biopsies by 3 months post-transplant. Why is that? Because at 3 months everything is settled down and the biopsy is normal. We win off steroids in those in whom it was still on board, except the highly sensitized patients and desensitized patients. For those in my center, for those who have T-cell mediated rejection, we always repeat a kidney biopsy 1 to 2 months after, just to be sure that everything was cleared. And for sure, if it was ABMR, we also repeat the biopsy not only 1 month, but also 6 months later. So your suggestion is very wise, because indeed you cannot rely exclusively on serum creatinine, as you said. And so it's wise to advise having a protocol biopsy 1 or 2 months after the treatment of your rejection. So that's good.
Number 2 question is that in the subclinical antibody-mediated rejection, if you have 2 scenarios, one is you have a microvascular MVI,
Yeah.
and what do you do? And the next is MVI with a DSA.
Okay.
So other than optimization of immunosuppression, what do you do in your center? Creatinine is normal.
Okay. So we are facing very often with patients with MVI lesions without anything, with or without DSA, with or without DSA. My assumption is that when you have MVI lesions without DSA, this might be non-anti-HLA antibodies, this might be endoendothelial cell antibodies, or NK-mediated lesions.
Self-mediated.
Yeah, NK-mediated, yeah. So what are we doing? So really, if there is no microalbuminuria, if microalbuminuria is nil, if serum creatinine is normal, but just MVI lesions, we do not, and no DSA for sure, we do nothing, and we repeat the biopsy 1 year later. Conversely, if we have MVI lesions plus microalbuminuria, stable serum creatinine, but microalbuminuria, with or without DSA, we start tocilizumab therapy. Why is that? Because it has been shown that blocking IL-6 pathways might be helpful in limiting the production of antibodies by B cells and plasma cells. And so there are some studies in the literature demonstrating that the use of tocilizumab or clazakizumab in the setting of chronic active ABMR might be worth it. And so we are just about to publish a paper in which we treated 40 patients having MVI lesions with or without DSAs, okay? And at the end, they were treated with tocilizumab, for at least a year, and so up to 4 years on a monthly basis. And so we found that almost three-fourths of the patients were stabilized with regards to serum creatinine, decrease in microalbuminuria. Those who have DSA, there was a decrease in DSAs, and we repeated kidney biopsies. And in the kidney biopsies, 2 scenarios. 2 2/3 of the patients had an improvement on their MVI score, and 1/3 no change or even a worsening. And those patients were about to lose their kidney. So at the end of the day, because rituximab is not worth it in that setting, IVIG neither, blocking IL-6 pathways might be useful in some patients having MVI lesions. And tocilizumab is available in Pakistan. It's not that expensive.
Regarding the details of one of the study, we were talking about the transcriptional profiling. So regarding that, for me and my fellows, how to do that? Profile.
Yes. Yeah.
One is MMDX.
Yes.
Profiling.
So I didn't pick up the last part of your question, but the MMDX is valuable in settings where there is discrepancy between your analysis and the pathologist's analysis. Or if you were to have a BK virus nephropathy with a lot of T cells around or mononuclear cells, this might be rejection associated with BK virus nephropathy. So in those settings or borderline changes, what will you do with a borderline change? Okay, you will treat it or not. Well, you've seen the data, not that many. And the classifier, NDX classifier, will help you in treating in a proper way your borderline changes or your BK virus nephropathy associated with T-cell mediated rejection, you see. So there are very few cases in which it's valuable, I think. Or if you've got isolated MVI lesions, but if it's MVI, most likely it's ABM or Galaxy.
Excuse me, can you hear me?
Yes. Sure.
Yes?
Sir, I am Dr. Fahim Sleri. I am consultant nephrologist in Center Park Hospital. There is question, sir. You give very informative talk. Sir, when we get some rejection, subclinical rejection on protocol renal biopsies, then should we treat them or we alter our treatment according to subclinical rejection, especially for antibody-mediated rejection, as there is some poor outcome of antibody-mediated rejections?
So thank you for your question. It's a very good one. Indeed, if you've got subclinical TCMRs, it's quite easy to treat accordingly with steroid pulses. Conversely, if it's subclinical ABMR, you could do something, and this could be either in addition to optimizing immunosuppression, this could be either rituximab if you've got DSAs, or this could be rituximab and IVIG, or this could be tocilizumab if you only have MVI lesions.
Well, just last point regarding this borderline lesions, because they are they are being defined that these borderline TCMR, we should not be borderline TCMR. Only some of them may not be TCMR, they may be some may be AMR, or some may be nothing.
Right. Yeah. Yes, this is the case, Dr. Ali. This might be nothing. This might be ABMRs, really. And so you need to have on board the presence or absence of DSAs for sure. Because I came across with some case studies where we were in Pindi a few days back, in which my feeling is that they have DSAs, because the feature of these borderline changes might not be really borderline changes. Thank you.
Thank you, sir. Now, moving forward, I would like to invite Dr. Khawar Abbas, a profound professor of pathology at Sindh Institute of Urology and Transplantation. He'll discuss regarding desensitization in renal transplant.
Thank you for the invitation. So I share our experience renal transplant in sensitized patient SIUT experience. So I start with the history. अच्छा, इधर से करूँगा. Not working. I start with the history. This is the first kidney transplant performed at Necker Hospital, Paris in 25th December 1952. The mother was the donor and this young boy received kidney from mother. The patient not received any immunosuppression and the graft lost after 21 days. And at that time, Dr. Jean Hamburger concluded that the complement was normal and gamma globulin fraction was elevated. It is therefore possible to hypothesize that this increase was due to antibodies against the transplant itself in 1953. In 2011, they retrieved the biopsy specimen from the archive of the hospital. They reevaluated the biopsy and published their findings in American Journal of Transplantation in 2013. And it shows that the rejection was mixed types, T cell and B cell mediated. So this is the first successful kidney transplant performed by Joseph Murray in identical twin, with the smiling face of recipient and little bit anxious donor. And few years later, Dr. Fleming described that hyperacute rejections of kidney allograft associated with preformed antibodies. And in 1969, this landmark paper of Paul Tarasaki comes and he described that in 225 patients, when there is donor specific antibodies, 80% of the graft lost within 48 hours, and if there is no antibodies, 4% graft loss. So this test is not perfect because in 20% graft is not failed even though there is antibodies, and in 4% when there is no antibodies, graft fail. So the need for HLA testing in kidney transplantation. So if this DSA is pre-existing and expressed in high level, the patient may experience hyperacute rejection or acute ABMR. This was described by Tarasaki in 1969. If levels are low in pre-transplant scenario, the most likely patient encounter acute ABMR. And late ABMR involved development of de novo DSA. So our goal is simply to avoid the hyperacute rejections with high level of DSA, so we can get away with using insensitive method. And if we are looking accurately to assess the acute ABMR or late ABMR, we should be better off using more sensitive HLA antibody testing method. So there are three types of cross-match currently are in used: cytotoxic cross-match, plus flow cytometric cross-match, and Luminex-based antibody detection method. So the in complement dependent cytotoxic cross-match, simple. We need just recipient serum and donor cells, incubate them and see the results. This is the results. In the black, this means that the recipient had antibodies against donor mismatch HLA antigens, and this small refractile cells means the cross-match is negative, recipient had no antibodies. So positive cross-match is contraindicated for transplantation because patient can lead to hyperacute rejections. And this is how we report. This is weak positive, 2 means these are the weak positive, and 8 reaction means the cross-match is strong positive, means high titer antibodies are present. So we also exclude the non-HLA or autoantibodies by doing auto cross-match, incubate recipient serum with recipient lymphocyte. If cross-match is positive, we report this cross match is not contraindicated for transplant, and this is our experience. Our experience, we performed around more than 200 transplants, auto cross match positive. And we also differentiate between IgG and IgM antibodies by doing DTT cross match, because DTT block the IgM. And the IgM cross match is also detrimental to the graft, because IgM antibodies are also complement fixing, and this can lead to the graft rejections. And IgG antibody, if the DTT is cross match is turned out to be positive and auto cross is negative, this is IgG cross match, and it's also detrimental to graft loss and can lead to hyperacute rejection. And we increase the sensitivity of the CDC cross match by adding anti-human globulin. It increase the binding sites, so it's more sensitive than classical CDC cross match, anti-human globulin. Come to the flow cross match. So I am not discussing the procedure, just focus on this side. On the right hand side, there is a senior dilution of the serum, 1:1, 1:2, 4, 8, and up to 1:128. And on this side, there is a CDC cross match positive. 8 means there is a strong cross match positive. 4 means 50% alive, 50% death, it's weak positive. If you see the cross match dilution of the serum, the CDC cross match become negative up to 1:4 dilution. But the flow cross match turned down to the negative at 1:128 or 164 dilution. So it's more sensitive flow cytometric cross match. It can detect low titer of the antibodies. It can detect non-complement binding antibodies like IgG2 and IgG4. And CDC cross match is less sensitive. Come to the third, the Luminex. In Luminex, the purified HLA antigens attached to 5.6 micron polystyrene beads, and bead is coated internally with 2 dyes, red and infrared dyes. And we add serum. If the serum had corresponding antibodies, it bind to the beads. For example, if the patient had antibodies against A1 antigens, so it's bind to the A1 antigens on the beads. Then we add secondary antibody, and then we add secondary antibodies, it bind to the antigen antibody complex. And we have 2 lasers, and the Luminex had 2 lasers. Red laser identify the position of the beads, and green laser determine the amount of antibody bound to the antigen antibody complex. So these are the position of the beads. So in 1.5 hours, we can identify 100 different specificities. And these are the high titer antibodies, positive, and on this side of the left-hand side are the negatives. So these are the beads we use, screen beads and single antigen beads. So in sensitivity, Luminex is the most sensitive assay, can detect very low titer of the antibodies, followed by flow cytometric cross match, then enhanced anti-human globulin cross match, and CDC is the least sensitive, can detect very high titer of the antibodies. So we don't know what is the risk at 2,000, 3,000, but at this MFI, usually flow cross match is positive at 5,000 MFI, and at 10,000 MFI, CDC cross match usually turn out to be positive. So if we compare the 3 assays, the CDC is less sensitive. It can detect very high level of the antibodies, and the solid phase assay Luminex is most sensitive. In terms of HLA molecules, in CDC method, the HLA molecules are naturally attached on the surface of the lymphocytes. So the way the immune system see in the graft, so it's the beauty of this assay. But in Luminex solid phase assay, they are artificially attached on the surface of the lymphocytes. We can find false positive because of autoantibodies, so we exclude these autoantibodies by doing auto cross match. In Luminex, we can also find the false positive because of the processing. the epitopes are exposed. So the antibodies can bind to these exposed epitopes and gives false positive results. And we can find false negative results in CDC method because the antibodies is there, but it's below the detection limit of the assay. And in Luminex, we also find the false negative results because of the processing. The epitopes is detached. So the antibodies is there, but there is no epitopes, so there is no binding. So considering the limitation of both assays, we can appreciate that each method has something to offer. So we use both methods, cell-based and solid phase, to complement each others to make better understanding of the immunological risk involved between donor and recipients. So we can stratify our risk by these three assays. So category 1 is positive for Luminex single bead assay, but negative for flow cross-match and CDC cross-match. Category 2 is positive for Luminex and flow, but negative for CDC. And category 3, which is high risk, highly sensitized patients, CDC, flow cross-match, and single antigen positive. And I will show you some relevant data and share our experience. So this is the study from the Basel groups. Their historic control, 67 patients. They retrospectively determined HLA-DSA with a mean MFI around 6,000, and the patient was transplanted between 1996 to 2004, and they considered low risk on the basis of CDC and flow cross-match. So there is no inductions, and the maintenance immunosuppression was cyclosporin, MMF, and prednisolone, and they found acute rejection episodes around 46% in historic control groups. Then they formed the ATG control groups, comprises of 37 patients. They prospectively determined HLA-DSA with a mean MFI around 2,000, transplanted between 2005 and 2008, and they consider for high risk because of DSAs, even though the CDC and flow negative. So they induce with antithymocytes globulin and IVIG, and their maintenance immunosuppression comprises of tacrolimus, MMF, and prednisolone, and acute rejection episodes was 11%. So this is our data. First category, CDC negative, flow negative, and the single antigen positive. These are the 78 patients in this group. These are their demographics, recipient and donor genders, and their ages. These are the mismatches. Around 8 patients are 1 antigen mismatch, 13 are 2 antigen, 27 are 3 antigen mismatch, and 10 4 antigen, 15 5 antigen match, and 5 patients are 6 antigen mismatch. So these are the pre-transplant DSA MFI. DSA class 1 MFI 3,294, and class 2 MFI around 3,000, and 7 patients had both class 1 and class 2 DSAs with this MFI. So this is their immunosuppression protocol. We induced with antithymocytes globulin 3 to 5 milligram per kilogram for 7 days, and their maintenance immunosuppression. Routinely, our maintenance immunosuppression protocols of patients who are not sensitized are more than 1 haplotype match. So their maintenance immunosuppression comprises of cyclosporin, azathioprine, and prednisolone. But in sensitized patients, this is our maintenance, tacrolimus, MMF, and prednisolone. So at 1 year, their mean creatinine was 1.16, at 2 years 1.21, 3 years 1.13, and the last follow-up, which was around after 5 years, the mean serum creatinine was 1.34. This is EGFR in the study population, rate of infections, UTI, and CMV. And these are the acute rejection episodes. Around 10% patients experience acute rejection episodes. 4 are T-cell mediated and 4 are antibody mediated. So antibody mediated statin was re-evaluated in all patients with biopsy proven. We not routinely do Luminex after transplantation in these patients. Only indicated when there is a graft dysfunctions and then we do Luminex. And post-transplant DSA negative in 7 patients out of 8, and 1 had persistent DSA against HLA class 1 with the MFI, mean MFI around 7,000 in AMR group. Now, come to the second group, in which in the follow-up group of these patients, 8 patients died in the follow-up period, 7 due to cardiopulmonary arrest with functioning graft, and 1 due to sepsis with failed graft. So now the second group, which is CDC Luminex positive, flow positive, but CDC negative. 16 patients. This is our prospective study. There's their 10 patients are male, 10 recipients are male, and 6 patients are female with this age group, and the donor was 6 male and 10 females, and the mean HLA match was 3 antigen. So the CDC cross match negative, auto cross match negative, AHG cross match was negative, and we run cross match in dilution to rule out the prozone phenomena. So the flow cross match Luminex positive. So this is the flow cross match positive mean channel shifts. This is the T cell positive 76 mean channel shifts positive. We consider in T cells we consider 60 mean channel shift, less than 60 mean channel shift as a negative, and in B cells less than 90 mean channel shift as negative. So T cells positive mean channel shift was 76. In B cell the mean channel shift was 141. And these are the Luminex results. HLA class 1, 13 patients were positive on HLA class 1, and 3 patients positive on class 2 with this MFI. So this is their protocol. We do plasmapheresis 5 to 7 sessions in these patients according to the antibodies. And after each session of plasmapheresis, we give IVIG 100 milligram per kilogram body weights. And day before transplant, when the cross match was negative, we give 2 gram of IVIG, single dose of 2 gram IVIG day before transplant. So this is at the time of transplants. After treatment, flow cross match become negative, and the MFI of the patients was decreased, but not negative. So this is their induction protocol. We induced them with antithymocytes, globulin, 7 doses, and the tacrolimus, MMF, and prednisolone was their maintenance immunosuppression. And this is their post-transplant follow-up at 3 months. Their creatinine are at this. At 6 months, around this 1.12, and 1 year, 1.19. And out of 16, 2 patients experience rejection episodes. 1 patient at 6.5 month post-transplant with AVR and mild IFTA, and patient 2 7 month post-transplant with PT and glomerulonitis. And 1 patient lost their graft in the follow-up period, and all patients are alive. Come to the third, when the CDC flow and single antigen positive. Enrolled 12 patients in this group. So our decentralization study is to eliminate or reduce antibodies against donor HLA to a level that permits successful transplantation. So we remove antibodies by plasmapheresis, block antibody functions by IVIG, it's an immunomodulatory. B cell depletion by rituximab, and plasma cell depletion by bortezomib. And most effective approach is the combination of three therapies. So we use plasmapheresis, IVIG, rituximab, and bortezomib in this group of patients. So what is the risk of desensitization? There are two large studies, high dose IVIG and low dose cetirizine on the Johns Hopkins. So their experience, Johns Hopkins experiences the cumulative incidence of infection at 1 year range from 50% in recipients who received no desensitization to 73% in those who received high intensity of desensitization. So there is no statistically difference. And the cetirizine group shows that the incidence of fungal, bacterial, and viral infections in desensitized patients and non-desensitized patients was similar. And there was no statistically significant trend toward higher rate of BK viremia in the desensitized group. And there is no cancer risk in desensitized patients. This is recently published in Transplant Direct. So high acute, this is a 21 studies published between 2000 and 2010. They included 725 patients with DSA positives, and kidney transplant performed with different protocols, high dose and low dose IVIG with or without rituximab. So the graft survival was 86%, and the patient survival was 95% at 2-year follow-up, and acute rejection 36%, and acute AMR 28%, which is significantly higher than those in non-sensitized patients. This is Hariran experience, short and medium term outcome in sensitized and non-sensitized patients. So graft survival in non-sensitized patient at 1 year was 97%, and 5-year survival was 86% compared to in cross-match positive, the graft survival was 89.9% and 5-year survival was 69.4%. So this is our SIUT desensitization protocol. We immunize all our patients before commencing of this protocols, pneumococcal polysaccharides, vaccines, and Haemophilus influenza, and at least 4 weeks before to start this procedure. And these are desensitization protocols. So we use single dose of rituximab at least 15 days before transplants, and we do 7 to 8 sessions of plasmapheresis, 1 cycle of bortezomib, and after each session of plasmapheresis we give 100 milligram per kilogram body weight IVIG, and at the day before transplant we give 2 gram of IVIG, 2 gram per kilogram of IVIG day before transplants when the cross match was negative. So at the day of transplant, all CDC cross match become negative, turned out to be negative. This is their post-transplant monitoring. We check CMV, BK, and EBV virus in all patients, and we give valganciclovir for the CMV protection up to for each patient for 3 months. And this is their maintenance immunosuppression, TAC, MMF, and prednisolone. So this is the case 1, 18 years old male, AB positive with this BMI, and end-stage renal disease secondary to stone disease. Left nephrectomy was performed. Biopsy shows acute on chronic non-specific pyelonephritis. Plasma oxalate level was this, and he remained on hemodialysis for 5 years because of this sensitization. Patient was sensitized. Donor was mother, 47-year-old, B positive with BMI of 24, and her creatinine clearance was 100 ml per minute. So this is the family history. The only donor available in the family was only mother, because the father was hypertensive and the siblings are less than 18 years. So this is one haplotype match or one haplotype mismatch. In the yellow, in the yellow is the matching antigens, and the white the mismatch antigens. So B57, CW6, DR7, and DQ9 are the mismatch antigens, and this is her This is a CDC cross-match, positive into 1:4 dilution T cells, and the B cell in was 1:8 dilution, and DTT cross-match is also positive. Flow cross-match positive with the T cell with the 80 mean channel shifts, B cell with 170 mean channel shifts, and these are the antibodies detected by Luminex, DSA against B57 and DR7. So we desensitized, and it's the at day of transplant after desensitization is CDC cross-match turned out to be negative. T and B cell flow cross-match negative, and the PR and the DSA decrease to this MFI. B57, our detection, our cutoff value for Luminex is 1000. 1000 below, MFI below we consider negative. DR7 around 1200. So this is his follow-up, 1 year, induced with ATG. After 7 days we stop ATG, and at 7 days his TAC level was 8.5. We checked CMV at 1 month, CMV, BK, and DSA at 1 month. DSA was negative after 1 month, then 3 months, 6 months, 1 year, and up to 2 years. So this is his timeline. His serum creatinine increased at 2 months because of the UTI. So UTI was treated, and then creatinine goes down. So this is his 2 years. So in these lines, we follow all our 12 patients. This is all 12 patients' data. All patients remain on dialysis 5 years, 24 months, 48 months, 30 months. And these are donor, match, CDC cross-match positivity 1:4, 8, 2, and 8. These are the titers and the DSCs. So these are the 12 cases. And this is their after transplant creatinine at 3 months, 6 months, 9 months. These are the creatinine rejection episodes. Case number 2 experienced rejection episodes. Infections, for CMV infection and the UTI. And case number 4 had experienced rejection episodes 15 days post-transplants, and 2 episodes of UTI. And case number 5 also experienced rejection episodes. So these are their follow-ups. Some patients completed 2 years, and some patients are in our follow-up. So highlight this case. This is a 35 years old female with A positive and end-stage renal disease secondary to unknown cause, and she remained on hemodialysis for 4 years. The probable donor was her brother, 26 years old, O positive. This is her family tree. Father and mother was diabetic, and 2 brothers and 4 sisters. All sisters are married, and in-laws refuse sisters for donation. So the only only probable donor was 2 brothers. So this brother came as a potential donor. This is matching. These in the white are the mismatch antigens. This is the positivity. This is a high titer antibody. So the cross-match, T cell cross-match positive into 1:64 dilution, and the B cell cross-match positive is to 1:128 dilutions. So flow cross-match positive, and all mismatch antigens had donor-specific antibodies, So we know that the key of desensitization protocol lies at what titer we select our patients. If the titer is about 1:164 or 1:128, it's very difficult to eradicate these antibodies. So our selection criteria is low titer antibodies. We select 1:4 or 1:8 titer. So we call another brother, and fortunately, this brother turned out to be HLA identical. So we transplant this lady with this brother. with ATG inductions, and transplant was performed in 2019, and her last creatinine was 1.02. So in conclusions, the early results of this study are encouraging. The long-term risk of rejections and allograft loss are not known. So living donor kidney transplants in highly sensitized patients is more successful than ever before because of these immunosuppressions. And the protocol employed in the current study offer real hope to these patients unlikely to otherwise receive the kidney transplant. Thank you very much.
So, congratulations on this very nice presentation and for the study you are performing in SIUT. So, regarding your desensitized patients, do you perform follow-up biopsies or 1 year?
No, this is not our protocol. We are not doing protocol biopsy. Only indicated biopsy.
Okay. And did you have any rebound of DSS post-transplant?
Because we are not checking DSS, we are only checking DSS that there is a graft dysfunction.
Okay, thank you.
Thank you.
So tea is being served in the dining area, or we will do after it. So okay, we will move forward. Our next speaker is a dynamic physician, Chairman, Department of Nephrology, Dr. Adil Manzoor, who has made significant contribution in the field of renal transplant. He'll discuss regarding post-transplant GN.
Assalamu alaikum and welcome everybody, and very thankful for all of you to coming and embracing the occasion. We are very delighted to have you. Post-transplant, as you know, it's a resource limited country. The young boys of 20-25 years old are coming to our doorstep with shrunken kidneys, and we don't know the etiology of this disease. And post-transplant, we are all the time worried about that the disease which has affected the kidney is coming back, and we are checking serially their proteinurias, and when the disease comes with a vengeance, we are hampered with the limited resources in a resource limited country. The treatments what we have, the plasmapheresis, the IVIG, and the monoclonal antibodies recommended are quite expensive for a resource limited country. So let's see what we can design our practices to a poor country or a resource limited country. So it's a slightly a bigger topic, but we'll slightly try to make it very easy and palatable. So it's the third leading cause of kidney graft failure, and with the death with a functioning graft. And as you see in the upper, if it is not visible, the FSGS is one of the most common cause of recurrent glomerular disease post-transplant. And in a living donor transplant, believe me, rejection is not such a big concern as this recurrent disease. And what we have seen almost in 632 transplants, that we have a significant number of recurrent disease coming to us, and we are doing the biopsies and then when treating, and we have success to some extent, but in some cases we have been unable to salvage the graft. So FSGS is the most common cause in the recurrent GN. And also here, just look at the third. This pointer is not working. Okay. One more thing here, that the C3 glomerulonephritis in Pakistan is really a difficult thing to dissect. C3 and atypical HUS, because we don't know, these patients go to the periphery, to the hospitals, and proper workup is not being done for these patients. You don't know that there is a thrombocytopenia, whether there is an acute event, there was a TMA-like event, or there was systemic hemolysis. and that has not been clearly dissected, and then they are coming with the shrunken kidneys for transplant. And as you know that these atypical HUS and C3 glomerulopathy are the diseases of the alternative pathway, whether there's a defect in the mutation or there is an autoantibodies and it's in the context of the C3. Don't forget that a monoclonal antibody can stimulate the alternative pathway as becoming a C3 nephrective factor as part of that. So there are too much obstacles in our country regarding the diagnosis, pre-transplant, diagnosis of the, so we have to be very vigilant post-transplant that we catch them early, and with the limitation with Dr. Mubarak only having the electron microscopy, as we know, the diagnosis of C3 other than immunofluorescence is really picked up on the electron microscopy, because there are around 2-3 types of C3, the dense deposit and C3. And transplanting in patients with atypical HUS with the mutations like the big mutations like the factor H and the factor I mutations without an eculizumab is virtually very a stupid thing to do. And similarly with the C3 also, if you have a mutation and you or autoantibodies to transplanting this patient without an anti-C5 drug is really not a right step to do. So we have to keep on this mind that there is a living donor who's there, and there is living donor has some risk here of this in the population like 0.3 or 0.5 by different. So we have to be very careful that what we are doing, we are exactly knowing what we do. So I always like to start with a case. So this is a case, diagnosed case of FSGS at age 23 with nephrotic range proteinuria and swelling at age 23. And remember that she has presented with proteinuria and swelling when he first came. Now she has come for a second transplant. First transplant has failed after 3 years due to recurrent FSGS. Comes with multiple questions. Now when you're taking the patient, the history of a patient with recurrent FSGS, it is very important that you say that how the disease starts, because FSGS is a pattern of injury. A lot of things are put into this basket of FSGS and they're labeled as primary FSGS. And we are only concerned with the primary FSGS, which is the permeability factor mediated, which is due to the immune mediated, and that is an issue as a part of the regarding the recurrent disease is concerned. And all the studies which are done in the recurrent, the investigators have tried to dissect that these patients are really presented with nephrotic syndrome and proteinuria. If they are not presenting with nephrotic syndrome or proteinuria or swelling or nephrotic range protein, this is most likely not a primary FSGS, and the recurrence will not happen in the graft. So in the history, the number one point is the history presenting with the nephrotic syndrome. As you know, this is a important, where if you look at the podocyte is the very important component. FSGS is a disease of the podocyte. Podocyte is anchoring your basement membrane very well. If the podocyte, if you look at the left side and if you look at the right side, the abnormal podocyte, this will not anchor the basement membrane and the filtrations will become white and your proteinuria will become more, and the slit diaphragm will become widened. So these are the important concepts first to understand before embarking further in the talk. And you see that another challenge in Pakistan, if FSGS, we do a transplant, FSGS comes with a 20 grams of proteinuria. If you see that on the light microscopy, it's almost a normal glomerulus. On the day 6, this biopsy is done with a normal glomerulus, so you cannot pick up in Lahore. But actually what has happened that the foot processes have virtually effaced. Look at the foot processes that have virtually effaced, if you look at that on the EM photo. So the early pickup of the disease in FSGS in recurrent is very important. Once you wait, that sclerosis will develop, the patient is not going to respond to the treatment. So early effacement of the foot process of detected on EM with the clinical presentation with the 20 grams of proteinuria has to be has to be taken care. And this becomes a challenge now. So again, I have come to that this FSGS is a pattern of injury. Many things come into it. And in the literature, the recurrence has been defined in a wide way. Look at these ranges, 20 to 80%. Why is this discrepancy? Because people have been unable to tease the primary permeability factor mediated, immune mediated FSGS from the other causes. Because the true recurrence of that primary FSGS, the immune permeability or permeability effect is 32 to 33% as by the, but when they are unable to dissect from the studies whether it's a genetic, that is because of a secondary, that is because of any other drugs for obesity, adoptive, or because of any viral process which is causing the FSGS. So these are the different factors. We are just interested in the left one, the systemic FSGS. This will be only occurring, which has many immune mediated mechanisms. The genetic is very important also. There are two types of genetic FSGS. One which is with the nephrin mutation, and the other one is the COL4A5 nephropathies. Remember, this subject, COL4A5 nephropathies in the world now is really, this subject is on fire. Previously, we were noting that this is only Alport syndrome. Now we know this is not Alport. It can present with FSGS, it can present with IgA nephropathy, it can present with wide variety of manifestations. Then you have this ApoL1 disease, which is in the African Americans, which is causing FSGS. And this is the problem, that when you select an African American donor, you look for the risk variant. If you have two risk variants, you don't take a donor from an African American, because their survival and the survival of the graft in the recipient is inferior if you go to this ApoL1. And remember, the genetics are how much important to dissect the genetic FSGS, that this will not recur in the transplant. Except with a few case reports of nephrin mutation, the recurrence of a genetic FSGS is virtually zero. So you have to be, if you have classical patient who has got a steroid resistant nephropathy, nothing is responding, you better do a genetic test for it. Otherwise, don't keep on subjecting these patients to calcineurin inhibitors, because what will happen, that patient is not responding, you start calcineurin inhibitors, and the time to ESRD will just decrease because of the drug toxicity. So it's very important. You have gone to a one layer of therapy, steroids, cyclosporin, patient is not responding, 20 grams of proteinuria, then a genetic study by a whole genomic is required in this patient. And you are very much comforted, this patient develops ESRD, he is not going to recur. Then we have the other varieties of FSGS. We don't need to go into too much details of that. And this is a very good experiment. If you look at this experiment, that if patient got transplanted and on the day 6, you see on red line, focus on the left side, proteinuria starts coming, and the GFR starts dropping in this patient. 6th day, that kidney is removed from the patient and transplanted into a diabetic recipient. Proteinuria comes start, and the blue line, the GFR starts improving. So it is the environment and the milieu in the recipient which is causing the FSGS. So 6 days, it remained in a patient who was FSGS. Graft was rapid proteinuria, drop in AKI, drop in renal functions. That graft is explanted and transplanted into a diabetic recipient, and what happens? Everything resolves. So it is the milieu in the recipient which is causing all these issues. If you look at again the biopsy, you look at the podocytes on the first recipient, all the podocytes has been effaced. And if you go into the diabetic recipient, the EM done on that shows that the podocytes have started reviving. They have started building. And after that, you look at the day 25 in the diabetic recipient. All the podocytes have been revived in this patient, and patient's proteinuria is gone, renal functions have improved. So a similar experiment, has been done 8 months by a person called Gallen. Kidney functioning in 8 years, florid FSGS, proteinuria, explanted, transplanted, rather everything became normal. So this is that environment, milieu in the recipient, which is extremely important. And these are the 4 factors which have been implicated in the recurrence of the FSGS. They have not been solidly, the studies are there, but they are not so much great convincing data, but these have been the 4 factors. The most important is the SUPAR, the circulating urokinase receptor, the SUPAR, which they have demonstrated that if you do plasmapheresis, you reduce the SUPAR levels, the histology improves, the renal functions improves, clinical manifestations improve, and they have done even to that they have done the molecular patterns of these studies that the cause of that FSGS, the matrix deposition by extracellular matrix, that has also started decreasing. Then is the 7 panel of antibodies that are anti-CD20. They are also implicated in post-transplant FSGS. And then APOVAL, and the first one is cardiotrophin-like cytokine. My friend Mujtaba in Galveston, he has done also a study on the use of ATR antibodies pre-transplant and FSGS, because as you know that ATR antibodies are one of the causes of non-HLA mediated angiotensin receptor mediated AMR, one of the causes of non-HLA mediated antibody, and you give ARBs and you do plasmapheresis pre-transplant and you get the ATR levels optimal before. What he demonstrated that if you have very high levels of ATR antibodies, angiotensin type 1 receptor antibodies, these patients over the period of time do develop FSGS. Now we come to the 3 important questions. Are there any reliable factors, patient characteristics that may predict recurrence? Does genetic testing help predict recurrence? And how should recurrent FSGS be treated? These are the 3 golden points in this one. Are there any reliable factors? So if you go to all this non-registry data, this sums come. The younger age at onset of FSGS, a rapid progression to ESRD. The term, the collapsing FSGS, which was being initially used as malignant FSGS, these patients are the white race, the nephrectomy of the NIT. Previously, what people were doing of these patients to prevent the recurrent FSGS and second and third trust, they were doing bilateral nephrectomy. So that has virtually failed, and that has shown to be a more predictive risk factor for future development of recurrent. Similarly, pre or peri-transplant plasmapheresis and pre-transplant rituximab as a prophylaxis or peri-transplant have shown no benefit, because previously saying the patient is very high chances of recurrence. The first transplant, the recurrence occurred. We're going for the second transplant. So what should we do? We give a rituximab and we give few sessions of plasmapheresis before that to just get the permeability factor down. But that has shown to be of no benefit virtually in these patients. Higher donor age, lower number of HLA, living donor, and duration of dialysis, that has been posed some risk factors. The most important are rapid progression to ESRD and white race. This is an analysis of all these studies for which was done for this purposes. This is a Tango consortium, the #1 study now looking for the post-transplant glomerular disease. And what they found that in out of 11,000, they defined 253 patients with FSGS. Now look at the right, excluded patients, very smart people, no nephrotic syndrome at manifestation. So they are not putting the FSGS just like a lesion, they know this is a pattern of injury. If the juniors take 1 point out of this conference, that is good, that FSGS and MPGNs are pattern of injuries. They are not diseases. So they smartly ruled out that no nephrotic syndrome. They have excluded that FSGS lesions. And then they dissected that it occurs in about 1/3 of the patient. That is the true recurrence of the first transplant. And this is all the registries, the US registry, the Brazilian registry, and the European registry. And when the FSGS occurs, we have seen here also, when it occurs very early post-transplant. If you look at the right table, less than 6 months, most of the patients are occurring within the first 6 months. And we see here, they are also occurring within the first 6 months. show a disease which is occurring, because many people get confused. A biopsy done at 4 years post-transplant, a proteinuria is 1 gram, and there is some, the donor was small, recipient was big, that is an adoptive FSGS. And the albumin is normal, you don't need to treat as a primary FSGS. What I have seen in my experience in Saudi and here, that the albumin goes down very quickly in this primary FSGS. They have the albumins like 1. So you have to correlate everything with it. You have to treat the primary disease. Don't subject to unnecessary therapies where they are not needed. It was because of a mTOR inhibitor, or it was an adoptive injury like this. Once you have recurrence, the graft survival in these patients decrease. If you have no recurrence, the patients with primary FSGS have similar graft survivals. This is the same table which I have already told you about, that age at diagnosis and all these things with the predictors. And here, it's, if you see that if you have a first graft loss due to a recurrent event, the chances in the second are 45%. And then the third is almost 100%. Now here comes an ethical question in a living donor transplantation, that will you be offering a patient who has failed 2 transplants because of FSGS a third transplant, where the chances of recurrence are so high. Just next question, does genetic testing help predict recurrence? As we know that there are many genetic now mutations in these patients, mucodistin mutations, the nephrin mutations, and the adult alpha-actinium mucodistin mutations. Using genetics to stratify the risk of nephrotic syndrome is very important. If out of 187 patients, 26 who were steroid resistant did had some genetic mutation. And there is the patients who have a genetic mutation do progress to ESRD. So be careful. By treating the native kidneys, do not subject to more calcineurin inhibitors and making their ESRD period shorter. If they go into ESRD without your only on conservative therapy like ARB, if you give calcineurin inhibitors, cyclosporin, they will occur very early. And here look at that, genetic form was 0 per 25 transplant. 28% of patients at recurrence post, the rate of recurrence in those with genetic is virtually 0. So that is a very safety and comforting factor, that if you have that patients, that kids, that small children that can be transplanted without the risk of recurrence, and nobody should be deferring their transplant. So this is the one of the indications for genetic testing. Definitely, if you have 2 family members and they have a clinical picture of an FSGS or a glomerular disease, you should be doing a genetic testing. Complement mediated traces, if you are suspecting, please don't be on board for transplant for these patients. They require investigative test from the genetic point of view, the dissecting of the complement factors, the complement antibodies, and the monoclonal before embarking transplant, both for atypical Hus and C3 glomerular. These are complicated diseases. They need really good investigation pre-transplant, and in Pakistan we cannot afford lifelong eculizumab for these patients. There are different methods to do a genetic. I think in Pakistan you have to do a more of a logical approach, because the test is costing about 250,000. Now another update, that in these patients now, another thing coming in the patients with the FSGS is a nephrin autoantibodies. They are found on immunofluorescence. There is what we were knowing, that there's immunofluorescence is completely clean in FSGS patients. But now they are finding that there can be granular dusty IgG appearance, and they are basically anti-nephrin antibodies. And they have demonstrated this one in the transplant also, as in the recurrent cases also. So this is because my pointer is virtually not working, if you can see that there in there's some deposition of IgE in subset of minimal Jane's disease patient in FSGS. And whenever using these antibodies, you remember in membranous or other things, you have to do a confocal microscopy to demonstrate that the Ig antibodies or antinephrin, they co-localize with each other. This phenomena is called confocal microscopy. This is for membranous also. If you are looking at anti-PLA2, you co-localize with IgG4, and this is same for the minimal change disease also. And here is in the nephrin, in the mid-bed, if you look at the nephrin, that is an essential component of the slit diaphragm. And when you have antibodies, this slit diaphragm, the blue one is virtually destroyed. And this is a case that post-transplant, FSGS recurring, one case report, and when they gave him plasmapheresis rituximab, and when they checked the antinephrin antibodies, they were positive in these patients, both by the ELISA and by the immunoprecipitation assay. And when you put antinephrin, take the plasma of these patients, of an FSGS recurrent patient, and infuse into rat, they become albumin uric acid. So this is a very simple experiment also. And they can also, when induced in the podocytes, if you see in the lower bar, antinephrin antibodies in the lower bar of that they will make all the podocytes apoptotic. They will be just vanishing. So this is another experiment. Treatments. What we have and what we can do. We are instilling plasmapheresis. We starting with 10 sessions, and in between we are giving rituximab here. And this is almost the standard of care. Plasmapheresis, in between you give rituximab. We're giving about 500 milligram of rituximab, and sometimes we are repeating another one. The other things in this one is that some people use a high dose calcineurin inhibitors. We maintain the TAC around 10 to 12 and during the acute episodes. But long time before, when these therapies were not, people were running cyclosporin levels very, very high, like 600, 800 in patients with recurrent FSGS. Abatacept is another drug. That's another monoclonal. This belatacept, Dr. Rostang just spoke today. It's another co-stimulatory block. But it has worked in those patients who have got B7 staining on the podocytes. And that has got a very good response in recurrent FSGS. Just like a drug like abatacept, but you have to demonstrate the B7 staining on the podocyte. Then you have the LDL apheresis. This is another form of plasmapheresis. I have not done, I have no experience in that. That you use high dose steroids, instead of plasmapheresis you use LDL apheresis, and people have shown very good results in the pediatric population. Patients resistant to plasmapheresis, you can use anti-TNF drug also, infliximab and all the things. ACE inhibitors has to be on board, SGLT inhibitors has to be board, and sparsentan, the combination of endothelin and receptor antagonist, and ARBs. Now here, if the patient, what is the response to all this treatment, plasmapheresis, rituximab, which is the main? Unfortunately, the response is not so very good. Okay, if you look in this slide, the complete remission, the partial remission, and the no remission, if you have a complete remission, these patients do very well. Even if I have a partial remission, I have experienced these grafts do linger on with ACE inhibitors, but no remission, they just, the graft survival is very, very. But even if you unable to achieve complete remission, don't be too disappointed. You get a proteinuria less than 2 grams, even that will work, and the graft survival will increase in this patient. The same rule applies for the native FSGS also. So here, see here, complete remission only 21%, and if you combine the complete and partial remission, it is only 36%. So 21 plus 30, so the response is not great. What happens with the patients with FSGS recurrence post-transplant? That requires months and years of plasmapheresis for remission. That I have a personal experience also with this one. The patients who have initial response to treatment, increase in proteinuria when apheresis was weaned, were successfully countered by reinitiation fluorescence. This means that you have initially proteinuria from 20 has come to 1, plasmapheresis is weaned, proteinuria comes back, you restart plasmapheresis. Similarly, after failed attempt to reduce the frequency of apheresis,
A second slower tapering schedule was in some cases successful. Slow tapering schedule, for example, 3 times a week start, then 2 times a week. Then you can go even to 2 times a month. I had a patient in Saudi Medina who was, when I was reducing the plasmapheresis, was trying to stop, he was becoming floridly nephrotic. Edema was coming and proteinuria, so I was keeping him on 2 times plasmapheresis per month. And I was saying to him, he said that Dr. Adil, doing 3 times a dialysis, I find 2 times plasmapheresis per minute and more convenient to myself. So patients have been on plasmapheresis for long period of time, but in our resource limited country, I don't know how long we can do for this patients, because albumin, people are unable to bring the donors for the FFPs also. Patients who are stable on a long-term parameter had lost 1 or 2 prior, because which could be informative in the discussion whether to revive. This is the ethical dilemma I was talking. Third transplant, 100% recurrent, whether a living donor in a Pakistan young brother 20 years old should be considered or not. So this is where recurrence is associated with reduced, another graph, and another the same emphasis. And remember, the patients who had initial no response in the first few sessions, if they do not respond, the further chances of responding are not great. So further, if you go keep the rituximab and other, the initial response has to be demonstrated. Now we come to the second topic, the recurrent membranes. It's very common in Pakistan, recurrent membranes. Probably it's the number 1, I think, the disease in the Pakistan population. So how we approach this disease? 5 to 13% of membranous nephropathy have clinically appearance recurrence in the allograft. Allograft loss occurs in 10 to 20. So it is also a big problem, as we think that we are ignoring this one, but it is really a big problem also. Now, its incidence will also depend whether you are doing a protocol biopsies or you are just serially monitoring the proteinuria or the anti-PLA2 levels, which we do here in PKLI. So this is the biggest study. This is from Mayo Clinic. They have, out of 115 transplants, 24 with first diagnosis of membrane, 20 patients included, 9 patients with recurrence, and 11 patients with another recurrence. And if you do a protocol biopsies, remember, you can pick up the disease early. See here, if you do protocol biopsies, you can pick up the disease. We are not doing protocol biopsies. And then they say that let's look at the anti-PLA2 levels of these patients who are membranous nephropathy and who got transplanted. So they had a look at the in the recurrent cases, look on the left side, out of 16, 10 were having positivity. And on the non-recurrent, out of 7, 2 were having a positivity. So what they concluded, that a positive anti-PLA2 antibody pre-transplant was a positive predictor value for a recurrence. So new patient coming with an anti-PLA2 or a membranous for transplant, always check the anti-PLA2 antibodies before transplant. So there are 3 groups. There will be a membranous nephropathy, no recurrence group. Then there will be a histological recurrence, no proteinuria. And then will be a clinical recurrence, biopsy consistent with MN and increasing protein. Histological recurrence will only be picked up on protocol biopsies. Histological recurrence does not require treatment. A clinical recurrence, especially 1 gram of proteinuria, will require treatment with an anti-CD20 drug. So now let's look into these groups. Recurrent by biopsy, MN by biopsy, no proteinuria. So 3 positive antibody and 1 initially antibody negative by 12 months, 2 antibody PLA2 negative shortly after transplant, and 3 remained anti-PLA2 negative. So this is no proteinuria. So most of them became negative after transplant. So the protocol in this study was ATG and a triple regimen. So most of the cases in membranous nephropathy, thymocyte globulin, ATG, and the other drugs, steroids, and tacrolimus and Sebtar are enough to take care of the recurrence, most of the cases. But I'll tell you in which cases you will require something additional. No evidence of recurrence, so most of the patients, they were negative, 2 were positive, and they also became negative. So the protocol of ATG steroid was sufficient in recurrent membrane to take care of the anti-PLA2 of these patients. And then the clinical recurrent patients. 7 positive antibodies, 5 remained anti-PLA2. So persistence of antibody or non-disappearance of antibody post-transplant is a risk factor for developing recurrent membranous nephropathy. This is despite all this robust induction protocol and a robust 3-drug regimen, some of the patients remain anti-PLA and they develop the clinical recurrence. So that's why it is very important to monitor post-transplant proteinuria, anti-PLA2 levels who are anti-PLA2 pre-transplant. That's where they said that, okay, anti-PLA2 is a predictor of transplant. Similarly, very high grade proteinuria pre-transplant is also a predictor of transplant. The cutoff was 1.5 gram. If the patient pre-transplant has a 1.5 gram, his chances of recurrence was not shown to be statistic. But if it is very high, like for example 10 grams pre-transplant, they have also like anti-PLA2 chances of recurrence. So this is the summary. 5 to 7 with anti-PLA2 pre-transplant remained positive post-transplant, and 2 had no available sample at the time of recurrence. In those who had histological recurrence, all had negative intuitive. Persistence or recurrence, I'm again emphasizing, and it may be help predict that those have clinical recurrence. Patients with biopsy staining of anti-PLA2 may have normal serum levels. Small amounts of antibody, look at my heading, sink effect, which is attached to the glomerulus, may cause clinically significant disease. The antibody is there, but it is not in sufficient quantities to be detected in the serum. They are attached to the glomerulus, like sometimes the DSS get attached to the glomerulus or the PTCs, and they are not detected in the serum. The DSA is there, but it's not detected. Similarly here also, it is not detected in the serum. So that is got a very good prognostic value also. This is a follow-up of that study which I was telling, that the same thing, that recurrence happened in PLA2 positive patients and progressive proteinuria and treating. And here what we're saying, that like wise FSGS, the disease is occurring within the first year, occurring early. So there were no significant relationship between risk of membranous nephropathy and donor factors, immunosuppression and recipient factors. But look at the pre-transplant proteinuria. It is a very strong risk factor for the recurrence. Other than this, there was no significant recurrence. And similarly, they have found that anti-PLA2 was also a risk factor pre-transplant for recurrence. Follow-up of the if you have a histological recurrence, how these patients do. Histological recurrence, no significant proteinuria, small grade proteinuria, less than 1 gram. Over the period, these patients remain stable and their clinical course remains okay. So that's why they suggest, unless you don't have a clinical recurrence along with an histology, don't treat. Histological recurrence is not equal to clinical recurrence. Can we predict recurrence? There is studies regarding HLA-D and PLA2 risk alleles that they have shown that single nucleotide polymorphism 7 types between HLA-DRB1 and HLA present in the donor can predict the membranous nephropathy. And they have devised genetic scores, many. These are the mismatches which can predict the membranous nephropathy recurrences. But these studies are small studies and they are not, they have not very large populations to do. And you need next generation sequencing, and we don't have the next generation sequencing. So the same thing found donor recipient HLA-B65 mismatch and donor recipient HLA-DR12 match contributing to prediction models for recurrence. Sample size is very small. I don't know what you can make out to 25 patients. And look at this slide. This slide is a very important slide. If you have a yellow is one anti-PLA2 level more than 150. And you just look at the left side of the curve, that how it has got such a strong predictive value for recurrence. So you do a anti-PLA2 level, if it is more than 150 in these patients, the disease is going to recur very, and this requires an intervention. So that's why they defined it. The other antigens, as you know, there are 29 antigens in membranous nephropathy now, and they have demonstrated that post-transplant nil antigen membranous nephropathy, they can recur. SEMA4 and 3B, they can also recur, and they have the case reports for that. And then, not to forget, monoclonal gammopathies causing membranous in elderly populations. They have shown here a case of proliferative glomerulonephritis with monoclonal immunoglobulin disease, the IgG3 kappa disease, stimulated by a monoclonal. So you are transplanted and you are not knowing that a clone is hitting, and this is going to cause the problem post-transplant. And they have demonstrated a patient that it will come with a vengeance back, because in monoclonal gammopathies, the main is that you have to get the clone negative, and you have to demonstrate no plasma cells, no free light chains, or kappa lambda ratio should be negative, no monoclonal spike, and fish, the cytogenetics, the mutation should be non-existing for monoclonal. So monoclonal diseases cause membranous also, and they are causing issues in the transplant also. This is that case, the immunofluorescence shows of that case. Treatment now. As we know, we have Mentor trial, anti-CD20, we have Ponticelli regimen, and people use cyclophosphamide. And what is the standard in a post-transplant setting? So you have, it comes again, and proteinuria is there, you initiate the therapy, and it starts. So you treat only the clinical recurrence. The threshold for using anti-CD2A is 1 gram of proteinuria with clinical histopathological picture. So what is the response to the treatment? We have very good response here, PKLI, all the patients which we did, they just responded completely. 50% will have a complete response, 31% will have a partial response, and 19% will have no response. Now, those who will not having a response will not do very well. And remember, the regimen used is the same as what we use in the Mentor trial. Rituximab day 0 and rituximab day 14, along with your ACE inhibitors, SGLT inhibitors. In patient with recurrent membranous nephropathy, graft survival did not differ from that of in patients with recurrent and who achieved complete remission from the patients with non-recurrent, patients with IgA nephropathy, or patients. So if they are treated adequately, complete remission is occurred, proteinuria has come down to 0.5 grams, the graft survival, and we have seen here also, graft survival is similar and not having much of issues. 2 of the 3 patients unresponsive to lost their graft with them. If they are not responding, the FSGS story, that graft is not going to survive very long. These are all the registry studies they have shown. Some people said that we'll observe this proteinuria. We will not treat aggressively with the histopathological patterns, and their outcomes were poorer. And these are all these studies which have compared that with the treatment versus the non-treatment group. Now we have another drug. All my colleagues must have seen resistant membranous nephropathy in the native population, and they do not respond. I have a kid now, he's cyclophosphamide, he's a combination of cyclophosphamide and rituximab, he's not responding to everything, we even give plasmapheresis. Then there is a new anti-CD20 that is called obinutuzumab, that has been used in post-transplant also. It is a synthetic, it is a more efficacy as compared to the rituximab, and it is being used in the resistant cases post-transplant patients. Then you have botuzumab, we are also using a lot, Dr. Khabar in AMR also. So that has also been described in recurrent membranous nephropathy. And now the pre-transplant workup, this is the very key when a patient comes to you, what you should do. you try to take the block and try to stain. If anti-PLA2 status, do the anti-PLA2. Try to take the block, try to stain it for anti-PLA2. In these centers, they do mass spectroscopy. Mass spectroscopy, like MMDX, Dr. Lionel was saying, is a technique that all the antigens are defined. What I saw, there are 29 antigens in membrane. So they define the antigen which is causing the membranous nephropathy. Now the other living donor, you should proceed. The important thing is that if you have, look at the lower pair, if you have anti-PLA2 more than 150 or either pre-transplant proteinuria more than 1.5, give them pre-transplant rituximab. This patient's recurrence will decrease. And after the transplants, follow close monitoring of these patients with proteinuria at least a month, bi-monthly anti-PLA2, protocol biopsy, since this is not relevant for that. And if their anti-PLA2 is serially climbing, be on the chase for that the disease is coming along. As in the native, we know that the immunological remission occurs early and that the proteinuric remission occurs late. If the immunological remissions come out, anti-PLA2 was 400, now it is 10, even the proteinuria, and we wait for 1 year for the proteinuria to get resolved. So same things you also demonstrate the immunological remission. This I have told you, that's all. Thank you. Questions? Oh.
So, thank you so much, sir. It was surely an enlightening talk. I had a couple of questions regarding the PLAR and the monitoring. Let's suppose if the proteinuria is 900 and we are in 13 months down the road after transplant, and the PLAR is on the rise, but the proteinuria is 900. So what would you do in that?
I think borderline cases will still go for the biopsy because 900 is almost reaching the 1 gram.
All right.
Borderline.
So another thing, with FSGS, peri-transplant use of rituximab is of no use. But
no
with
use.
membranous,
Peri-transplant plasmapheresis, no use.
But with membranous, it may be of use.
Rituximab, if your anti-PLA2 level is greater than 150 IU.
All right. And what about bortezomib? What's the practical experience in a post-transplant period?
Post-transplant membranous nephropathy, there are few case reports of bortezomib. You tried an anti-CD20, it didn't work. Then you tried obinutuzumab, or if obinutuzumab was not assessed, they tried bortezomib. And virtually their proteinuria and the disease has just fallen down. It's a very good drug in Pakistan settings in antibody-mediated rejection treatment also.
And have you used it?
We are using in AMR a lot here.
Bortezomib. Okay, but not in membranous.
Membranous, we have not a single experience here.
All right.
In native as well, because all are membranous patients. One is Dr. Sham patient, the rest are mine patient. All have responded to anti-CD20 in a fantastic way.
Is there any cutoff of PLAR or won't be comfortable doing a transplant?
Yeah, more than 150. We will do that, we'll give first rituximab, but we will not stop transplant. This is a very golden point. You will not hold transplant only solely on the base of anti-PLA2. And some people will even disagree with this approach also, that about 150, more than 150, you should give rituximab. There will be some people who will be advocating that just the way I showed you the Mayo Clinic data, that might be ATG, your triple robust immunosuppression tacrolimus steroid may be sufficient to take care of it. So this should, that point, that 150 has also be taken with our, because this is something very new.
Thank you, sir.
Congratulations, Dr. Adil, for this very nice overview and experiences with FSGS and membranous nephropathy. Just to highlight membranous nephropathy, how complicated it is, we recently have the case patient. So he has MN in 2018, PA2R positive membranous nephropathy. He was treated with 2 courses of rituximab and PA2R decreased, but he lost his function on his native kidneys. He was transplanted 3 months back. Anti-PKLI2R antibodies were negative the day of transplant. We gave him, nonetheless, 1 shot of rituximab, and he developed de novo proteinuria 2 weeks after transplant. And the biopsy on 1 month post-transplant, it was still negative in the blood for PKLI2R, but the biopsy was positive with PKLI2R. So we gave him 1 shot of rituximab. So just to say that it's fine to have a negative rate, if possible. But in that case, I was very surprised in my case, and it's very disappointing because when the recurrence is there, it's very hard to decrease the proteinuria.
But biopsy staining was positive for PLA2. Biopsy staining.
Only that, yes.
Only that. That I told you, the sink effect. The antibodies are there, but they are not detected in the serum.
In the last year, we have 3 cases with me and I think Dr. Adit cases. So in my cases, all of the patients have anti-PLAR in the serum negative, but they were positive on the biopsies. So they have proteinuria of around 5 grams, 8 grams, and one has 7 grams. After rituximab, they are in the remission phase.
Excuse me, Dr. Atal. First of all, it's a very informative talk. I just want to ask, do you have any your data so far at PKLI? What are the regarding the recurrence of GN here, and what are the outcomes here?
Yeah, we have not compiled the data, but we have fairly large experience in recurrent disease.
And what you just
We have lost grafts because of FSGS.
Okay.
I think two grafts have been lost.
Also, what you say about the second transplant in a patient who is having recurrent FSGS?
I think we can go with the second, but definitely not the third in a living donor. But I want to have opinion of Dr. Rostang also. Second, I think we can take a chance.
I agree with you. We can take a chance for a second transplant. And when the recurrence occur, well, performing daily plasmapheresis, rituximab, as you said, in between, sometimes we can get some success. We have published a recent series of data regarding immunoadsorption, specifics for immunoadsorption, in those cases who were refractory to everything, FSGS recurrences. And it worked in 5 out of 7 cases. At the end of the day, they were induced into remission. And we applied immunoadsorption for refractory membranous nephropathy recurrences, and it had no effect. So, different diseases.
Yeah, thank you.
Challenge.
If you could comment on the recurrent rates of FSGS, membranous, and IgA in general,
Yes.
and typically what you have seen over the PKLI in the
I think
last few years.
FSGS and membranous I have told you. IgA nephropathy I will tell you. That I've told you the recurrence rates here are almost the same. IgA nephropathy, which we have seen here, IgA nephropathy post-transplants comes in 2 flavors. One is a smoldering microhematuria, proteinuria coming in patients, and we put them on we give them a bit of steroids like the testing 2 trial, and we give them ACE inhibitors and SGLT, and these patients, all IgA nephropathies are going fine with me. Their creatinines are not rising, their proteinuria becomes very low with this ACE inhibitor, SGLT combination, and a modest dose of steroid, which I only give it for 1 to 2, not like the testing trial for 6 months. Then there is a variety, a phenotype of IgA nephropathy, which comes in the post-transplant, which is a very aggressive form, which is a crescentic IgA nephropathy. And believe me, nothing responds to it. We give Plex in a patient. We give this was not a PKLI patient, this was an outside patient. We give Plex, we give cytoxin, we gave rituximab, okay, and along with the high dose methylprednisolone, and did not recover, and eventually the girl lost the graft. So remember, IgA nephropathy comes with 2 flavors. One is the smoldering one, which is not harming the graft. Mild proteinuria, but one, if crescentic IgA comes with AKI, creatinine is 1, coming to you with 5, crescents all over, whatever you do is not going to respond.
What's the percentage? You have
I have seen in Pakistan only this outside patient, crescentic IgA.
1/3 recurrence in FSGS, 30% in membranous nephropathy. That's how it is.
20.
20%.
20%.
And for IgA, what's the
For
percentage?
IgA, the problem is that recurrence you cannot define so much, na, because it will be a wide variation. You don't know donor has brought the IgA. In diseased donors, I've just made a decision regarding a liver transplant, believe me here. Hisham has seen all the biopsy with this one. The patient is having DCLD. I will share you interesting. Creatinine is 2.9. And biopsy done by myself, proteinuria, where there was 1 gram. And there were all IgA deposits. No chronicity, no IFTA, tubular vessels were okay. And I had took a chance. They said simultaneous liver kidney versus isolated liver. I said isolated liver. And the patient is doing very well. Creatinine has started coming down. You don't know that 50-year-old donor is carrying harboring IgA nephropathy. It is subclinical. Biopsy done for some other purposes, for example, protocol biopsy or biopsy done for TCMA shows IgA deposits. So the true incidence of IgA nephropathy in transplant is virtually impossible to define. You don't know donor is carrying that one. Okay, and most of the IgA will be going silent. They will be having a normal graft survival. Just picked up on protocol biopsies, incident biopsies, cause biopsies. Thank you. Now T.